right, welcome to everybody on the line. Thank you for participating in the webinar with us today on rural behavioral health. Today's topic is mobile response and stabilization services. We'll go ahead and get started. My name is Shannon Robshaw. I'm with the TA Network, and along with Sarah Warner, we're the key contacts for the Rural Behavioral Health webinar. We invite your feedback and comments on this webinar. We invite your suggestions for additional topics. In the coming months, we usually have webinars on a bi-monthly basis on a variety of topics, and would welcome any suggestions that you may have for future webinars. When you registered for this webinar, you are automatically added to a listserv, the Rural Webinar listserv. If you do not want to be on that listserv, please email Sarah or myself and let us know when we will remove you from that. Otherwise, you'll be on the listserv and you will be receiving recordings of the rural webinars. Each of them are recorded, and we send those out to everyone on the listserv following the webinars. So thank you again for being here. Executive leadership, supervisor, board member, or volunteer. It's always great to have volunteers participating. Parents. Anyone else want to let us know what type of role you serve in your organization? Family support provider. All right. Well, thank you for those of you that responded. All right, so we're going to move right into the presentations. We've got great presenters today. I'm very happy to have them with us. We have the first presenters are from Utah, leadership from Utah, and the second presenter is has been with the New Jersey System of Care, Liz Manley with New Jersey System of Care, and Liz is currently with the TA Network, but she, before that, with the New Jersey System of Care, was served as faculty at our Mobile Response and Stabilization Services small group meetings over a period of, I think we've had 3 or 4 of those small group meetings now, so Liz has been faculty on that, so she has experience not just from New Jersey, but from staffing that small group meeting and talking to a variety of states and communities around the country that are thinking about implementing mobile response and stabilization. But first we're going to hear from Ruth Wilson and Justin Naylor from Utah, who are leaders in the system of care development there, statewide implementation on a number of different a number of different system of care initiatives, very broad-based, but including mobile response and stabilization. And they attended the small group meeting that Liz was faculty on, and have been thinking for quite some time about how to best implement that service in a rural area like Utah. And so we're excited to hear from them. So I'm going to let Ruth and Justin, y'all take over from now, and then we'll take questions at the end of Ruth and Justin's presentation. We'll take a few questions. Then we'll move into hearing from Liz and take some additional questions at the end there. So Ruth and Justin.
Perfect. Good afternoon, good morning, depending on where you're at in our country. My name is Ruth Wilson, and my role is I am the director of System of Care for our SAMHSA grant under the Department of Human Services, and then I also am the Assistant Director to the Division of Substance Abuse and Mental Health over the Children, Youth, and Families. And Justin, do you want to introduce yourself?
I am Justin Naylor with the Department of Human Services in Utah as well, the Assistant Director over System of Care.
So we are excited to tell you a little bit about what we have been doing here in Utah. I wanted to give a little bit of an overview of our state. It's a big state, and it's approximately 85,000 square miles. And it takes about 7 to 8 hours driving from top to bottom. And depending on the time you drive, right, you're going to get there between 7 and 8 hours. We have 29 counties in Utah, and 6 of them are urban, and that is the blue. And you can see that the populations there, we define urban as 65,000 plus. We have 10 urban/rural counties and 13 rural/frontier counties with frontier areas in them. And we also have 9 Native American tribes throughout our state that we work with. So we have a large area to cover and to think about when we plan. The population is, these are 2010 numbers. And 2014 numbers, we have about 3.1 million people in Utah. And as you can see, of our folks, 2.2 million, live along that top part of the counties that you can see. And I'm going to go back to the state because I want you to see, if you start at the top and you follow the blue counties and all the way kind of down along the red to the bottom blue one, that's what we call our I-15, Interstate 15 corridor. And most of the population live in these areas. So that leaves us about, so again, the 2.2 million live in about 3,600 square miles, leaving about 81,000 square miles to house about 850,000 people. A little bit of a background on how we got into where we're at. A number of years ago, the director of the Department of Human Services and we were fortunate to visit New Jersey on a SAMHSA site visit and got to know their system well and met Liz Manley when she was there, and we were very impressed. And so fast forward 10 years, 10, 15 years, we are, not that long, 10 years, we find ourselves in a situation where we thought about that. The deputy director and I are both at the Department of Human Services, and we got a group together to visit New Jersey, and that was in August of 2016. And we brought, I think there were 18 of us, and we brought family, key legislators, state, county, local leaders. We included local mental health authorities and representatives from Medicaid. After we did that, and New Jersey again was gracious, system, what they were doing, we got back together again and talked, when we got home, and talked about the key takeaways from this New Jersey visit. And undoubtedly, every single one of those 18 people felt like the mobile response and stabilization service that New Jersey was offering was one of our top 3 key takeaways. And so as a result, we decided that we wanted to develop something similar. We wanted to have a statewide service, and we started calling it SMR services, the Stabilization and Mobile Response Service. The first thing that we did is that we created a planning group, and we gave this planning group instructions that we wanted them to sprint. It wasn't a task force or a group that would meet once a week for a number of weeks, months. It to be done rather quickly. It started in the summer, and the goal was to have a model developed by February before our legislature started. We solicited representation from urban and rural areas in all different, from all different departments, agencies, organizations, family, youth voice. The charge, again, was was to develop a model for Utah where we could implement stabilization and mobile response. The vision that we had was that we wanted it for any parent, any child with any problem at any time. And so that meant that it was not just about the children and youth in the public sector, or not just about children and youth in the custody of the state of Utah, but any child, whether it was private insurance, uninsured, funding, custody didn't matter. We found that we needed to communicate clearly the charge, and more than once, both verbally and in writing, the charge, our vision, and the expectations. We needed to make sure that we were clear on the outcomes and the deliverables, and then the time frame. And we asked for updates. We gave updates to our department leadership every month. Another piece that we found that we needed to communicate clearly was that we needed a structured process that was focused on the what. So we wanted a model. We were not asking who was going to do it or how they were going to do it, because those questions kept coming up, and there was a real tendency for our planning group to drift. And because they were really interested in what does that mean for me, my agency, who's going to do this, what does it look like, where's the money going to come from? We keep communicating back. We just need a model. The expectations for the model were that every person, family would have that consistent quality experience. We wanted to make sure we understood that our state was so diverse and large that it wouldn't be the same experience, so we wanted to ensure that they had that consistent quality experience. We wanted to make sure that the parent and the family, or the caller, the guardian, defined that crisis. So in the past, if they were calling the mental health crisis line for a problem, my kid's not doing well in school, it might be that the mental health authority might have said, refer you to your law enforcement or receiving center or another service, but we wanted to respond to any crisis. The parent and family define that crisis. We wanted to focus on partnerships, that in defining the response, it would be between the family or the person calling and the professional who was answering the phone to define the response, what would work for that family and that parent and that child. We also talked about a partner in decision-making throughout the process, and we wanted, again, available to all families and children regardless of funding or status. The model we wanted the model to have youth and family voice infused and at the table at every stage of the planning. We wanted it to be easy for families to access. We wanted it to have a strong front end. We felt like if we could do that triage, that assessment at the very, and that customer service at that very front end, that we could increase our engagement to engage with our families or the people that were calling in. We wanted it to be coordinated and timely. Again, focusing on accountability and outcomes at every stage, and that we wanted it available 24 hours a day, 7 days a week, and again, statewide. This is an example of the model that was, there were like many, many iterations of this model, and this is what it ended up looking like, where we have a triage function, a mobile deployment function, and stabilization function, and then we wanted to close the loop, and so we, I won't go through the model in depth, but those were the key components that we wanted of our model, and this is what we submitted, and this was accepted by our department. And then I can certainly answer questions on the model if you have any. Our little piece. Challenges from implementation. A challenge for us was that we wanted it to be statewide, and again, with consistent components, and we recognized that geography was going to be huge, given the urban and rural nature of our state. And population, again, along that Wasatch Front, that I-15 corridor was where the majority of our folks lived, And we struggled with making sure that we addressed those rural areas and those frontier areas. How could we respond? And again, the travel time. That played a big factor in how do you deploy someone, or how, if you feel like that, according to our model, if you triage it and you feel like you want to, and we want them there within an hour, many instances that's just not possible. And so that was a big challenge as we talked about how and what we were going to do. So our department of Human Services is comprised of many different divisions, and we're fortunate to have the Child Welfare, Juvenile Justice, Division of Services for People with Disabilities, and then Substance Use and Mental Health, all underneath this department. We struggled with how we would implement. The local mental health authorities, we have 13 of them that serve 29 counties. So it's a county-based system, and we have 13 local authorities. And 4 of those counties were being served currently by so there weren't a whole lot of them, and we thought 13 is pretty, might be bigger than we want to take on. Services for people with disabilities within our state is administered at the state level and in some local areas. Juvenile justice is administered by function. So depending on the function, and that is how we set up the administrative structure. And for child welfare, it's divided into regions. And so we thought, okay, let's go with regions. And we tweaked the regions just a little bit so that the local mental health authorities that fit within those regions were whole. So you didn't have a local authority split between 2 of those regions. And I might be going into a little bit too much detail. But I wanted to just tell you how we really struggled with how we could have this go statewide. We ended up going with our system of care regions. There are 5 of them. And you can see them on the map. Within each one of those regions then, we identified a local regional organization or an entity to act as a regional administrator. And when I say we identified, right now we're in the process of implementing 2 of those regions, the northern region and the southwest region. But for the others, we are not. So we are not there yet. We need someone to lead that implementation. Again, the model was the what, and the local regions were to determine how it would happen and how and who we would implement. That regional administrator would work with local partners. We wanted to make sure formal and informal were at the table, and they would establish a network of those services in each of the communities. This regional administrator would also be accountable for their region to the department and to the different system of care regional advisory councils that we currently have in place in those regions. The regional administrators would also work with the state to make sure that the SMR services included all of those core components, which were, again, the triage, mobile response, and stabilization services. They would make sure that the services were available to all of our children, youth, and families. And they would also make sure that the services were consistent with this model that we put together. They would make sure that we included those system of care values and principles, that they were available 24 hours a day, 7 days a week, and that the triage services work. We're finding that because of the rural nature of our state, may not be able to have that mobile deployment available, maybe during the graveyard shifts, if you will, but that triage live person needs to be available 24 hours, 7 days a week. We want to make sure that the parents and the families define a crisis. Data and outcomes are the same and standardized. And then they would be responsible to verify that services were delivered and authorizations were done prior to submitting for payment. So the lessons learned for us were many, and we tried to, Justin and I tried to think about how we could put them in pockets, if you will. The first one was that we needed to make sure that we balanced the model's core components that were consistent statewide, needed to be flexible, and knowing that the local regions, the frontier, the rural areas, would have to customize the service delivery, the how and the who, from the very beginning. And I think that's the key, that from the very beginning we had to make sure that we all understood that it would be customized at that local level. We found that we needed to use trusted local organizations and people and families, because there were a number of entities that were interested in being that regional administrator, but if they were not trusted in their communities or seen as a standard of high quality, that was not going to work. We also learned that the culture of each local community we needed to and customize to. And then the travel is a significant factor, both in time and money, and that the funding in the rural areas, the frontier areas, would need to be increased. And oftentimes we went back and forth with people thinking that the more populated areas, there's more people, we're going to be called out more, we're going to need those kinds of things. And we found that, yep, that is true, and we need more resources in our rural and frontier areas. The next one is that we wanted to make sure that we focused on the solutions, because there was a lot of barriers that were identified and challenges, and well, what about this, what about that? We came around and again focused on, okay, great, you're right, and let's focus on solutions. We wanted to make sure that we engaged local stakeholders in finding those solutions, that we as a department, as a state entity, it didn't work for us to come in and say, well, we think you need to do that. They needed to be the ones in leading and engaging and finding those. We wanted to incorporate local resources in those solutions. In some of those areas we're talking about, for example, in the most northeastern part of our state, working with local librarians who might be trained in providing some support to a family if they needed that kind of a support. So again, that mobile deployment might be someone that we've trained who is not a professional and who knows the community and who knows that, most likely knows the family and can be helpful and supportive. We wanted to maintain flexibility and creativity, again, and not go to that cookie cutter approach that is based on that local area. And a big one was that we need to remember that not all of our solutions are clinical. It seems that those of us that are clinicians, we tend to fall back in, well, what about this clinical service or the respite or whatever? They might need respite, but we would focus on an informal support that could provide that was not necessarily clinical. And then again, the last point that I didn't put on here, but as I was going through it, I thought, again, the main thing, another lesson learned is, as you're planning and developing a model that will work for your state, your rural area, that you focus on the what first. You need to make sure that we're clear and the expectations are there about what the model should be, and then allowing for that local community, local area, the rural frontier areas to determine the who and the how.
Thanks, Ruth. Let's open it up to questions. We've had questions in the public chat box right there. And we would encourage the questions. I mean, Ruth, I might, until we get additional questions coming in, could you back up the slides a little bit and talk a little bit about that model? You have the graph in there, and I would be interested in hearing a little more detail about how this really works.
Sure. So initially we wanted it to be one number for the state, and we struggled with how to do that with the 5 different regions. And so what we ended up doing is having one number that would be geo-routed to those 5 different regions. It will be one number, and we, again, we wanted to, in our perfect world, we wanted one entity to triage all of those calls so that they could be a standard response, a consistent. We would have that one group do that, and it just didn't work for us. And so at this point, we're mindful that we may need to change that moving forward, but as we started, we decided that one number that we would publicize, and it was pretty clever on our local, our Southwest region came up with 1-833-SAFE FAM, and so that is our number, and again, it's geo-routed. So when the call comes in, there's a phone triage, and okay, let me look. There's a phone triage. That's some operational criteria. Not all of it. It was pretty. We just wanted enough to get to our legislature, right? So understanding that we did have criteria and that we were going to collect data. So once the call comes in, they triage it. They determine if it is and needed to be called. If we've got to call 911 or an emergency service. Thank you. They determine those kinds of things, and if it needs to be mobile deployed, or if they could pre-authorize for stabilization. They could do it from that triage place. And we thought about the stabilization piece right from triage. That would be for families or callers who might have called in 1 or 2 times before and that we had deployed and that we knew them and could route them to the stabilization service piece. Otherwise, we would deploy on every other call if it wasn't resolved or if the parents or the caller was not. And so we had a plan that the mobile deployment could be initiated within 1 hour. It could be initiated for a psychiatric response. Again, if we deem that they need hospitalizations, it would be initiated with 1 hour, and all other emergent ones within 1 hour. Or within 24 hours, we could initiate that deployment, or within 72 hours. Depending on what the family felt comfortable with. Because one of the things that we heard was that at times that families, just knowing that they had an appointment, they really didn't want to disrupt their family sleeping in the middle of the night, that they could wait till the next day or at a time that was more convenient. And then under the mobile deployment, you have activities that those could include within that 72 hours to stabilize that crisis. The outcomes of that mobile deployment would be that the crisis was resolved and they felt like the family could benefit from the stabilization services, which would be an intensive 6 to 8 weeks. We could refer to that. Or the crisis is resolved and that was it. And so we, again, want to make sure that we closed the loop and gave the data back up to the triage folks that were responsible for the data. Or the crisis isn't resolved. And so we would re-engage the phone triage, or we would communicate and continue our support, knowing that additional things would happen. So that is the mobile deployment part of things. And then on the other side, again, the stabilization services would be up to between 6 and 8 weeks. And if the family, at the end, the outcome would be that stabilization was achieved, or not achieved, and then we would have additional decisions on what to do if it wasn't achieved or was achieved, and we refer to other supports. So that is our model.
That's really helpful. Thanks for walking through that. I had a couple more questions, but let's go to the chat box first because we've got some questions there. Peggy asked, do you have any counties that have rural areas outside of an urban one? Examples, King County, Washington, with large is as large as the state of Delaware and is a region of its own, it could take an hour or more to reach a rural county area.
Yes, we do. So you're right. We have some of our counties where you cannot get to them within an hour. And so what we decided to do in that situation is if they are calling into the triage, the administrator that does the triage, if it's a psychiatric emergency or if it is a mental health, that they would do what they normally do, which could be that you send law enforcement or you take to a hospital. Otherwise, we would work with the family, and hopefully in each one of our cities or towns, we would have a person identified who is our mobile response. It could be a family peer support specialist or a family that could respond to that family. And we want, and that's what we're hoping to establish in each one of those towns, that somebody could deploy to that family within that hour.
Okay, thank you.
I'm hoping I answered your question, Peggy.
And she also asked, do you have a crisis line for the general public that is separate from, or do you have a crisis line for the general public that this is separate from or coordinates with?
We do. We have, and we actually have legislation this session to have one mental health crisis line for the entire state. And we're excited about that because they can call into that one number, and we have already begun talking with them and educating them about our stabilization and mobile response. So if that crisis line gets a call that feels like, nope, this is not a psychiatric or a mental health emergency or a suicide prevention type thing, they will do a warm handoff, get us on the phone, and let us take over and do that follow-up with our mobile deployment or stabilization services. So again,
Great.
It's that coordination and communication, yes.
Thanks. I'm going to ask one more question and let's turn it over to Liz. When you're looking at the regional administrators, how are you selecting that organization? Are you going with the local mental health authorities? Are you going with nonprofits? Is it an RFP process, or how are you making those decisions?
That's a really good question. So we started in Southwest, and for that one region, there is just one local mental health authority, and they did have an MCOT team for children, youth, and families already in place. So we approached them wanting to build upon what they already have in place for those 5 counties and broaden that MCOT team, if you will, to that mobile response to all kids, all families. So we did go through a local authority there. When we went at the second area, and there's a question on there, so we're in 2 areas right now beginning implementation. The second area up north, there are 6 counties, and there are 3 local mental health authorities up there, one of which just shut down their MCOT team because for reasons of funding. And it was the largest one, and so we approached the largest mental health authority who had a lot of credibility with the other 2 and a lot of leadership, and they looked to them as leaders to be that administrator. So yes, we did go with 2 local mental health authorities. Along that Salt Lake region, that middle region, where we have Salt Lake County, which is huge, we're interested about how we might go about that. We've thought about private providers. We've thought about, because the local authority in this area does things a little bit with lots of providers. So they might have 300 plus providers in this area. So we wanted to open it up to hospitals if they wanted to take that on, Intermountain Medical Centers or the University of Utah health plans and departments. or it could be a private provider out there. It could be, so anyway, there's different thoughts about that. And when we talked about the private sector partnering with us, we're hoping that there would be some additional funding that they could bring in and infuse into what we're trying to do as well. And so, yes, we're looking at locals, and we're looking at other folks that we can have as those administrators.
Thanks, Ruth.
Okay.
Well, thanks, Ruth, and Justin, too, for your contribution to the presentation. We'll take some more questions at the very end, but I think now we can go ahead and turn it over to you, Liz.
Yeah, absolutely. So my name is Liz Manley, and I am formerly from New Jersey, so I'm going to speak today mostly about New Jersey, but also about some of what I've seen in terms of what other states are looking to do in terms of mobile response, states and counties. The mobile response peer-to-peer learning meeting that Shannon spoke about has brought over 20 states to New Jersey to learn about multiple models, not just New Jersey's model, but also the model for wraparound Milwaukee and for Connecticut's mobile response model as well. And with that, we've learned a lot about what other states are really working to do and how they are rolling things out. But let's start with New Jersey. Mobile response and stabilization is a service in New Jersey that has been around in New Jersey for over 17 years. It has demonstrated a tremendous amount of success in multiple ways that we'll talk about, but the data on mobile response is just overwhelming in terms of its success. So a little bit about New Jersey. New Jersey is a smaller, it looks like a smaller, but it's a densely populated state. So I know folks always ask me, how do you even talk about rural communities within such a densely populated state? And the answer to that is that the tips of New Jersey are very rural, have very, they're rural communities that actually have real challenges in terms of the delivery of services around behavioral health within them. And as the children's behavioral health person in New Jersey, I had to worry about how do you get equal access to care from the tip to the toe in New Jersey, and that was pretty complicated given some of the challenges, including challenges like in the northernmost part of New Jersey, there are multiple languages that families speak, and so you get the right person there at the right time for the right duration was one of our big challenges. The goal of the children's system of care was to move away from only having really two tiers in terms of services, from the low-intensity services like outpatient and high-intensity services like out-of-home, to really building an intensive in-home and community-based services and supports for families to be able to really move away from the overutilization of both inpatient hospitalization as well as out-of-state, particularly out-of-state residential care, and in-state residential care when it wasn't necessary. We did find that language is incredibly important, and a common language across the full state was really, really important, and moved away from words like client, cases, and placement because they're confusing to folks, and moved to a more common set of language. Like in New Jersey, the children's system of care speaks about children, youth, and young adults, and parents and caregivers, works on treatment, not on placement, because placement is really the work of the child protection and permanency, or the child welfare component, not the behavioral health system. Engagement was a really important focus. So the idea that folks weren't motivated was really just not even part of the vocabulary in New Jersey. It was the goal of the behavioral health system to engage folks who were seeking treatment, whether that be the youth or the family. And that transition was really important discussion, because the transition is the service delivery system stepping out, but the family really having a long-term sustainable plan, which is incredibly important. Moved away from the word missing in 2012 moved away from the word runaway in 2012 after Superstorm Sandy, and we recognized that we had a very large problem around human trafficking, and that the first problem was we couldn't even identify when youth were missing, and that's the first step to combating human trafficking, is really to look at when a youth is missing and to address it. And we did use mobile response as one of the strategies in addressing when youth are missing from wherever the adults thought they should be. And then we talk a lot about family time in New Jersey. In order to understand the New Jersey system of care, it's important to know what the components are. And so some of the components really start with a single point of access. And similar to Utah, New Jersey has one point of access, so one phone number. Ours isn't quite as creative as Utah's, but it is a 1-877 number that anyone can call 24 hours a day, 7 days a week. That ability to just call one phone number and ask for help is really, really helpful. The contracted systems administrator who answers the phone, right now that's an organization called Perform Care. Perform Care is available not only to dispatch mobile response and stabilization, but also to connect to other intensity of services necessary. So parents can call that number 24/7. And one of the things we did find is that families do reach out, and when they reach out to the public mental health system, the ability to get someone to answer the phone and to guide them to help has been incredibly important, even if it's a small number of individuals who call that number 24/7. One of the things I didn't say, and it's important to know, is that the Children's System of Care in New Jersey manages all the supports and services for youth with both moderate and complex behavioral health, substance use, and intellectual and developmental disabilities. So that 1-877 number is really important for families to be able to reach out when they have the ability to do that. New Jersey has a full continuum of care that includes care management. Care management is a more intensive. It's really used as a service that addresses the needs for youth with both moderate and complex needs if their needs can't be met in a short period of time or within the confines of like a outpatient program. Mobile response and stabilization, in a lot of ways, New Jersey sees mobile as a front door for care. And so the goal is to use mobile to de-escalate crisis that may not even feel like crisis to the system. As an example, when a parent of a 14-year-old calls and says, I don't know how to get my child to do homework, might not look like a crisis to other systems, but to ours, it looks like a crisis and feels like a crisis because the caregiver has said it is. And recognizing the stress level of the caregiver and the individual, the young person, is incredibly important in terms of moving away from overutilization of the higher intensity of services. And so when a parent calls and asks for help, the goal is to respond by providing help. And mobile response is one tool in the toolbox, but it's an incredibly important one because it's available 24 hours a day, 7 days a week, from tip to toe in New Jersey, and it's in every community has to respond within the course of an hour. And the work in making sure that the resources were in place, in the right place to be able to combat the challenges around the rural components of New Jersey, but also the real urban centers. Like in one of our communities, getting 6 miles within an hour is actually really complex because of the traffic that hits because of those folks commuting into New York City. There are parking challenges in some communities, but there are also these really, and I worked in one of the rural communities in New Jersey, there are real challenges around trying to get the right professional there at the right time. And so we had to really come up with a lot of different solutions in order to resolve the challenge of how do you get the right person at the right place within an hour within the state. And then we have a really important partner at the family support organizations to help our parents and caregivers really understand how the system works, and to provide guidance both through a warm line as well as through support groups, educational opportunities, and direct peer support for youth who have the most complex of needs. And then there's a full continuum of intensive in-home and out-of-home. There are supports and services that we had to build for youth with intellectual and developmental disabilities, with mobile response actually being one of the really important drivers to help us figure out what those supports should look like, in particular for youth with intellectual and developmental disabilities, because they led that transition or helped us really figure things out in 2012 when the governor made the decision that children with intellectual and developmental disabilities would come to the children's system of care. We have a full continuum of substance use treatment services, which is one of the most complex services to deliver for a lot of reasons. In particular, the engagement process for youth and families is really, really important, and having people who can answer questions and provide support and education on a regular basis to communities is really important in that work. So New Jersey Mobile Response and Stabilization Services is really about providing support and skills necessary to return the youth and family to typical functioning. That's the way that we think about it. And the way that happens is really with professionals going into the home and using a standardized assessment tool called the CAT. They use that CAT, or the Crisis Assessment Tool, which is an offshoot of the CANS, the Child and Adolescent Needs and Strengths tool, and it's just a smaller version of the CANS tool. And they use that CAT to begin the conversation of what is necessary. All mobile response workers are trained to establish communication and rapport with both the youth as well as the family to be able to de-escalate the crisis. And in New Jersey, the model allows for, there's two components of the model for mobile response. The first is the initial response or assessment period, which is a 72-hour period of time. That mobile team can be in place for an hour, for 5 hours. They can come in and out for that family as often as necessary within the 72 hours. And then there's an 8-week stabilization in which the mobile response team works to connect that youth and family to community supports, which may include outpatient but isn't specifically outpatient. And if there's still concern, great concern, then they actually can move to connect that youth and family to care management for a longer-term engagement. New Jersey's program elements include really the services available for individuals 21 and under, as long as the 18, 19, and 20-year-olds are making the call themselves. We've dispatched to a Starbucks or a diner if they asked us to. We need the parent or caregiver consent when the individual is under the age of 18, and so that has been complicated, for schools in particular to use mobile response and stabilization when they feel like a child's behavior is escalating. But we think that it's a really important component of care, because when the parent is at the table, the resolution and really happens much, much quicker. And then really it's about the escalating emotional or behavioral needs. So we define crisis as how the family defines the crisis, not in the way that a clinician might define a crisis. And we think that's really important. So what is it? We think that the crisis is just really when imbalance happens, that the youth might be struggling in school, they might not get off the sofa, whatever it is, the parent has gotten to a place where they feel like they need to pick up the phone and call and ask for help. And that's a really important component. The program eligibility, we do have clinical criteria. The clinical criteria are posted on the Perform Care website, which there's a link to at the end of this presentation. You're more than welcome to take a look at the clinical criteria for both the 72-hour as well as the crisis stabilization. We believe that, New Jersey did a ton of work around when do you say a crisis is a crisis, and came to conclude that there wasn't a single time where mobile response went into home where we thought, wow, we shouldn't have been there. So I think that's really an important statement on all of this. And it's also, to Ruth's point, when you talk about making mobile, you want access to be available across your full continuum. So mobile response to stabilization is available to any family across the state of New Jersey, any family, regardless of their ability to pay. If they're a New Jersey resident, the service is available 24/7. Program elements, we talked about the single point of access. There's a clinical triage component in which Perform Care is on the phone with the mobile response unit and the family. They resolve a couple of really important questions prior to mobile going out. Like there's a big question around dogs and guns in the home, those kind of things. Who's going to be in the home? What does the home look like? Those important questions up front so that everybody's on the same page. We have a much bigger issue with dogs and workers getting bit by dogs than we did with any guns or any violence within the home, but there needs to be a conversation specifically around dogs when we send our mobile teams out. There is a verbal consent that happens over the phone, and then there's a signed consent form that happens as soon as mobile walks into the house. There's a warm line transfer so that that conversation that happens is really important. New Jersey has a clinical record called Cyber that Perform Care begins to document all of the information into the record, and that record is immediately shared with the mobile response and stabilization. And then if the youth requires more care and goes into a care management organization, that record is actually electronically shared with the care management organization. Program structure is 24-hour response. There's 72-hour intervention up to 8-week stabilization. The New Jersey Children's System of Care actually manages a full provider of Medicaid providers who can provide care for youth whether they have Medicaid or not. New Jersey has a Medicaid look-alike number, so all providers bill the same way. For a child who doesn't meet the criteria for Medicaid, there's what New Jersey calls a 3560 number that's established for that individual, and that's how the providers bill. So whether that's the mobile response team or whether that's an intensive in-home provider who needs to go in and provide support to the family for 8 weeks, whoever that behavioral health provider is, they actually get paid through either a Medicaid or through the 3560 number. And then they can connect to those community-based partners like the Family Support Organization and support groups. The Family Support Organization also has a youth partnership, which is important for our youth to be connected, and that peer group actually does both recreational activities as well as advocacy work. There's a ton of work that gets done within the youth partnerships within New Jersey. And then we've worked really hard on engagement over the last few years. So the development and implementing a communication strategy with family we found was essential. It's essential for all youth because when a youth is experiencing a situation in which their parent or caregiver has called for assistance, there's generally the first thing that goes is the ability to speak in a clarity that people can understand what it is that's going on for you. That's also important, I think, when children have autism. So there's a huge autism population in New Jersey, and children could be nonverbal. And those children, the mobile teams do remarkable work with on a regular basis because the first strategy is around engagement and communication. We use a lot of technology to assist, and those technology components include, ways of communicating with youth. They include, in New Jersey, we use telehealth, we use Project Echo. There's a lot of other ways of engagement with families in order to make sure that we are responsive to families. We do outpost people all over the state, so having professionals outposted to particular communities is important, and there's a lot of sharing of support. So as an example, you might have a mobile response team that's actually housed not in their own organization, but in a family support organization or care management organization. It helps save some costs, but it also ensures that there's that the ability to respond 24/7 happens. And there's a lot of different ways that our organizations think about that work. And then we really connect to the informal supports in the community, because we have a lot of community partners in New Jersey that are part of the conversation and are helpful in terms of the development. So that's New Jersey. These are the two websites that I send you to. The VCF website actually has a lot of data around mobile response and stabilization, but I'll just give you one very consistent data point that I think is important, is that children who have used mobile response and stabilization, 96% of the time, 96 to 98 depending on the month, they stay in their own homes. They never go into a hospital. They're never removed. That includes children in foster care. And I'm just going to give you one quick anecdote around the use of mobile response for children who go into foster care. New Jersey, as part of policy for the last 2 years, have mandated that children over the age of 4 who are going into foster care, that mobile response has to respond. Now, mobile would respond, but this is for the workers on the child protection and permanency side of the work. They use mobile response. They call when they know that the youth is going into foster care, and mobile meets them when that youth arrives. And they have a very simple conversation with the child. They basically say, something big has happened to you, and because something big has happened to you, these things might happen. You might have a hard time eating, you might have a hard time sleeping, you might have a hard time focusing at school. These are okay. They happen to some people, they don't happen to all people, but if they happen to you, we know what to do about it. So we'll come back and help. And that conversation alone in the pilot that we did in almost 3 years ago now, 46 out of 46 youth who were removed from their home and went into foster care stayed in the first bed they went into, the first foster home that they went into, unless there was a planned move. And because of that outcome, New Jersey has moved to use mobile response and stabilization as part of the whole group of work. So that's New Jersey. I'm just going to touch briefly on a couple other states that are really working and communities that are working to bring mobile, who have really some challenges about workforce development and some challenges around how do you deal with the actual distance that you have to drive. And the quick answer to both of those is that this work is really complicated, but to Ruth's point, you have to set the vision of what the expectation is and where you want to get to, and then you're back towards the problem solving. That's what New Jersey had to do. We had to sit and say, okay, what do we want for our children, and what do we want it to look like, and then how do we solve that particular problem of making sure that every child in New Jersey has access to mobile response and stabilization 24 hours a day, 7 days a week, tip to toe, even during Superstorm Sandy. So how do you do that? And so the answer to this is, and what other states have concluded, is that it's just really important for us to know our communities, to know who in the community can help. How do we figure out who the best folks are to do this work? New Jersey, just to be honest with you, uses they use behavioral health professionals, but they use bachelor's level professionals, and they team them up, and then they use master's clinicians or really licensed clinicians to provide all the supervision and support for those individuals to make sure that the workforce is manageable. That works in New Jersey. It might not work in other places. There are other states that have chosen to only use clinicians to go into particular communities. The point is that there is a way to problem solve in the challenges that might come up. Okay, any questions?
We've got plenty of time for questions. You talked really fast, Liz.
Oh, I'm from New Jersey. I'm sorry. We talk fast.
No, that's great. Thank you.
That's part of who we are.
Please write any questions that you have in the chat box. I see someone's typing. So, Liz, for the rural areas in New Jersey, I mean, your strategy was to use non-licensed people. I mean, that was a prime. I mean, you said the tip and the toe. I mean, concretely, just understanding what's available in that community, or talk us through that a little bit more.
Yeah, absolutely. So what happens? So the requirement for our mobile response partners, and they're all embedded in larger organizations. So about half of them are in hospitals, and the other half are community, or not, a little bit less than half are in community mental health centers, and then there are a few nonprofits that have the mobile response contract. All of those contracts went through a request for proposal, and there was a submission of a proposal, and one of the major areas that the organization had to address is how they would put professionals in the home within an hour. So they had to be willing to outpost folks, work with other community partners on where physically their staff would sit so that they could actually be in any part of the area that they served within an hour. Now, there are parts of New Jersey, I didn't say that there are 21 counties and there are 15 mobile response units across the state. And so there are 2 mobile response units that actually cover 3 counties and a pretty good amount of territory. So it would take them well over an hour to go from one part of their the area that they cover to another. So they had to really be thoughtful about how they were going to outpost staff. So that's one part of it, like where do you put people? But the qualification part of the conversation, one of the struggles was New Jersey didn't have enough, actually physically have enough clinicians who could do the work to cover all that would need to be served. And so there was a decision made pretty early on that we would allow organizations to use bachelor's prepared frontline workers who were specially trained. So we have a certification process that all of our mobile response workers go through. They have to be trained in particular areas before they can actually begin the work. There's work that gets done that has to be supervised by, some have to be supervised by the actual licensed practitioner, and some can be, is part of the buddy system of who goes out there. We allow our mobile response workers, many are working on their masters, but not all. So we allow for the individuals to be a bachelor's prepared. What I know from the peer-to-peer is that there are some states and communities that weren't comfortable with that particular model. But I just want to say this, and I've said this before to the group, is that number one, we've never really had an issue with that. Like that, getting, when I was the assistant commissioner in New Jersey, I didn't have mobile response as the problem for where inappropriate practice was happening. And I sat on the board of social work, and that's not where it happens. It happens in other places. Bad practice didn't happen a lot in mobile, and it didn't because we had a very clear way of training and supervising the folks who go in-home and work with our youth. The other thing is we allow for 2 staff to go in whenever that's necessary, and that's deemed that's non-essential. That we have a lot of really skilled people in our system, and so the organizations themselves make those decisions, but they often will go in teams, and there's some mobile response organizations that only go in teams, some because of the communities that they serve, and some because they just feel like that's really the practice that they want to. So it's kind of, a lot of art and a lot of science in terms of figuring out the staffing. Hope that helps.
So, yeah, that does help. And so you have contracts with, I think you said yeah, I can't remember. You said 15 mobile response teams across 20 counties. And so those that are, I'm just thinking about financing. So 2 questions. Basically, how is this financed across the board? And secondly, with the contracts for those in the rural communities that may have to have additional, heavier staff because they're outposting, does the contract rate reflect that? Do you compensate them differently?
No, we don't. And one of the reasons that we don't is because, believe it or not, in the urban areas, they have to double up on their staff more frequently than they do in the rural. So there's sort of like this balancing thing that happens. And I think, and some of them, some of the mobile response units cover both rural and suburban, and there's this balancing kind of act that happens. So the budget for mobile is actually pretty. It's a well-developed rate that they get. So in my 5 years, there was not one mobile response team that lost money because of what they needed to do, because we would have compensated them. We would have figured out how to take care of them if there was a problem. But we do have all of our mobile teams actually bill through the Medicaid platform in New Jersey, and they bill every child as if they have Medicaid. So that's the other component, because you want to make sure that there's consistent funding, and so they get paid regardless of whether or not the child has Medicaid or has a commercial insurance plan. And the way that works is that the New Jersey, the Children's System of Care has a behavioral health carve-out, and so they use that carve-out for children who don't meet the criteria for Medicaid up front. And we actually, all the mobile response, all of our partners actually can presumptively make children eligible for Medicaid if they meet the fiscal criteria. So they work with Medicaid around that for kids who actually meet the criteria. But we have plenty of kids who don't meet the criteria. So the way that works is they just bill on the Medicaid platform. But they bill two different rates. And so they bill an assessment rate for every child who comes in. They're doing they're doing those assessment and using those assessment tools, and they bill in 15-minute increments on targeted case management for Medicaid, actually, for children who are in the 8 weeks of stabilization.
And so the kids that don't end up meeting the Medicaid criteria, I understand they're billing off of that platform, so that it's that lookalike. Yep. But is it state general funds that are used then?
Yeah.
Pay those kids? Okay.
Yes, it is. It is. It's the carve out. Yeah.
Okay. All right. So questions from anybody else on the line? Questions for Liz, questions for Ruth or Justin, Utah, New Jersey? Got something coming in, it looks like.
Shannon, we missed the question. Would you mind restating it?
No, I just invited people to ask questions to either you or y'all or Liz, and I thought I saw somebody typing, but I haven't seen the question pop up yet, so we'll see.
So Shannon, I see a couple questions. I haven't seen it. So there's one question around statistics on residential. Are the numbers seen higher in youth who are in foster care for residential? And, New Jersey has an interesting story on the residential side. Number one, New Jersey has worked to bring all children with behavioral health challenges back to New Jersey, so there's no out-of-state residential care that happens. That's number one. Number two, the numbers for residential care have dropped dramatically across the board, and that was because of the availability of home and community-based services, and that includes children who are in foster care. So the numbers, if you look on the New Jersey DCF website, you can see some of the data that just shows over time there's been a dramatic decrease. The other part of the data that I think is always interesting is that New Jersey has closed 9 detention centers, closed its first prison, and has reduced the population of youth on probation by 70% since the beginning of the children's system of care.
Yeah, and I see the questions now too, Liz. I hadn't moved my cursor, so you want to take that next one?
No problem. Sure. You got it. Let's see. Let me just make sure I have the right one.
Did you have any problems with clinicians responding to a crisis as identified by the parent?
There's a lot of training that has to happen. Yeah. So the answer is, so the way in the beginning we did. right? We had to really get people used to the system and say, just go, right? That's just the motto, just go. And but our partner at Perform Care actually makes the decision of just go. And so when they call, mobile has to go. And so there hasn't been there's not, I mean, believe it or not, they've been trained. It's 17 years they've been trained. This is what they do. They do it incredibly well. And they're really amazing partners in it. So in the beginning, there were cultural changes that really had to happen, and a lot of consistency, and a lot of saying, just go. You just got to go.
Okay, and then there's questions about the age of consent. What is the age of mental health consent in New Jersey, and how does that impact the ability to deliver services to oppositional defiant children is the question.
Sure. So that's a challenge, right? Because our youth have to sign off on particular behavioral health at 14. But mobile is an urgent service, and so because of that, that first initial assessment can happen without the sign-off. What we find is that our youth really love mobile. They really do. They don't generally run from mobile because the folks who come in are able to really engage and engage them quickly. So it would be a rare situation for a youth to say, I'm not signing that consent. And then we would address it. We'd figure it out. We'd figure a way of being able to help that parent be able to work on whatever it is that was necessary.
Okay. Great. And then there is a question, you see that last question was charity care is an option of payment. I'm not quite sure.
Sure. So charity care exists in New Jersey, but it really is specific to hospitals and inpatient units. Our system, you know, the children's system of care is built on the really on not using those high cost services, and the recognition that if you are really responsive early when families call, then you're going to keep them out of the emergency room. So we figure out the payment. And the payment is, like I said, a backdoor. It's part of the state budget. It is mobile responses built into the budget. It wasn't always. So these were part of the major conversations that had to happen around how do you build a system that is sustainable over time, that can be responsive to youth and families, that families like, that youth will engage with. So all of those conversations have happened over time. But charity care as a payment mechanism isn't one that the state uses to pay for youth who don't meet Medicaid criteria.
Okay. Thanks, Liz. Any other questions for Liz or for Ruth and Justin? We have just a few minutes left. We're happy to take some more questions if anybody has anything. I sort of had a question, Ruth. I thought I heard you say that in some of your regions that you may be using peer. Did I hear you say peer support providers to be the ones that respond?
Right. So thank you. Yes. Let me clarify that. So in some of our rural areas, especially we are pairing a clinician with a family peer support or a care manager. And they will go out together. So the clinician is there doing the in-depth assessment and guiding the work, and then the family peer support who's trained or the care manager will be the ones implementing the interventions and the work that's identified between the family and the clinician. So we'll be overseen by a clinician, but the family peer support will be that support and stabilization piece.
So they go out together? They physically go out together?
They do. That for the mobile deployment, they do go out together the first time.
Okay. And Liz, I don't know if you, Riverside County, California, I believe, you know, they have a mobile response system as well.
That's right.
They've been modified. I know you've been working with them recently too, but they, I believe, have both.
Yeah.
They have youth peer support on their, they have parent and youth peer support on their mobile teams, I believe. Is that, am I remembering correctly?
You are remembering correctly. It's very impressive what Riverside is doing. And I think they're going to see great success by engaging youth in that in the process. It's one of the things New Jersey wants to do, but you know what Riverside is doing is really impressive.
Great. All right, any final questions from anybody on the line? I would ask y'all to please stick around for a few minutes once the webinar closes. There'll be a survey we would ask y'all to participate in to give us some feedback on what you thought. We would appreciate that if you would stick around for just won't take very long at all, just to go through that real quickly. And if there aren't any more questions, do either of our speakers, any of our speakers have anything else they wanted to add before we wrap it up? All right, well, thank you all, Liz, Ruth, and Justin, for your time and for, you know, sharing all this good information with us and helping us think about all sorts of different strategies. And I mean, I think one of my big takeaways I heard is that you've got to be creative and you've got to know your communities, you know, mentally. So you've given us a lot to think about. So thank you to all of you, and thanks to everyone that joined today. And you can see the link to the survey in the public chat box. So please just take a minute or two and complete that for us, and we would appreciate it.